Good evening, everyone. Thank you so much for coming to our CNS Working Group. This is the first open session that actually we are doing in a big way, which is primarily supported by a grant from the Hope Foundation. So thanks to Jo Horn and her amazing team. And as a result, we actually have food. So those people who want to get dinner are more than welcome. We have a number of outstanding speakers and a stellar agenda. And obviously, given the constraints of travel, we have several presenters who are going to be dialing in through Zoom. So thanks to those who actually are here in person. And we've had a little bit of a change in the agenda because one of the things I didn't realize were how many people were going to dial in from the East Coast. And then that 5:15 Pacific is actually 8:15 on the New York time or Eastern time. And in interest of a family emergency, just changed the agenda a little bit around two aspects. One is that we will have all the people who are going to Zoom in speak first. So the three speakers who are here in person will actually go last. And we will have the people who are going to dial in go first. And because so Dr. Manesh Mehta is chair of NRG Oncology, who's done a stellar job of running high quality cooperative group trials in brain tumors over the years. He's actually the ideal person to kick us off. And so Manesh will dial in through Zoom, and he's going to talk to us about the lessons learned from NRG Oncology, what he and NRG Oncology has done an amazing job in the last 2 to 3 decades, and really offering high quality cooperative group trials for our patients. So something that we can learn from and collaborate more with them as we launch our SWOG CNS Working Group. So Manesh, if you can hear us, the floor is yours.
Yes, I can. Can you guys hear me?
Yes, we can hear you loud and clear.
Great. Am I able to share my screen?
Yes. You can hit share screen and you should be able to share.
Can you guys see my screen?
Yes.
Okay. Well, Manmeet and all the attendees at SWOG, thank you so much for giving me this opportunity to speak to you tonight about some of the experiences from clinical trials that I've had the opportunity to run, lead, and participate in. And most of this will come from NRG, but I decided to cast a wider net than that because obviously lessons come from all directions in life. And so I will use examples from different contexts, primarily contexts that I have been involved in. And these are really lessons primarily designed to make us more successful as we move forward with clinical trials. These are my conflicts of interest disclosure. And I will keep my talk succinct and focused on 5 key themes. The themes are as follows. Keep it simple. Make sure your clinical trials are easy to understand and easy to conduct. Keep it practical. They must be deployable to a wide number of institutions relatively easily and doable, and for patients to be able to participate in them. Know in advance how you will measure success, how you'll define it, and we'll have a game plan if you succeed. What do you do next? Similarly, you must have a game plan for what you do if you fail. So these are the 5 key themes that I hope to showcase using examples from clinical trials. The first one is actually an example that I'm going to bring from my work in ECOG. I used to participate in the ECOG Thoracic Cancer Committee, and I had the opportunity a long time ago when dinosaurs roamed the planet to design this trial, ECOG 2597. This was a trial that was based on very robust understanding of radiation biology and tumor cell acceleration during prolonged courses of radiotherapy. The understanding of this biology, primarily in the UK, by 2 well-known individuals known as Saunders and Dish, led to an attempt in the UK for rapidly proliferating epithelial neoplasms, particularly head and neck cancer and lung cancer, to try and shorten the course of radiation from the conventional 6 weeks down to 2 weeks. And to do that, they utilized a 3 times a day radiation therapy schedule, spaced 6 hours apart. That That meant that the radiotherapy department had to be kept open for a minimum of 18 to 20 hours round the clock, and patients would have to be hospitalized because obviously patients could not travel so many times for their care. And they would get treated 3 times a day for their head and neck cancer and for their lung cancer. The results in lung cancer were actually quite dramatic. They produced a significant survival advantage in favor of TID radiotherapy, which, if it were a drug, would be a blockbuster drug today, but has never taken off as a standard of care anywhere because it was far too complex. So we in ECOG decided we would do something really smart about this. And what we decided to do was to recognize that the standard of care for lung cancer patients had changed. And at that time, the standard of care had changed to sequential chemoradiotherapy. This is how far back this trial goes. And patients would therefore receive carbotaxol for 2 cycles. And after that, they would be randomized to standard radiotherapy, which was 64 gray in 32 fractions back then, or a TID arm where we would design it cleverly so patients would get 3 radiation fractions in an 8-hour day, and patients would not have to be hospitalized and would not need to be treated on the weekends. Therefore, they could remain outpatients. And the whole thing would be done in a very short 2.2 weeks. So we thought this was really, really cute. This is really, really smart. Little did we realize how much complexity we had built into this trial. So the trial got done, and these were the results. Arm 1, which was the standard arm. Arm 2 is the TID arm. The median survival was 20 versus 13 months, significantly better. 1-year survival rate, somewhat comparable, 53 and 59. But look at the 2 and 3-year survival rates. They were definitely superior on Arm 2 compared to Arm 3. In fact, all of these numbers matched the hypothesized delta that we had built into the trial going forward. In other words, the trial mechanics performed exactly as hypothesized, with one little caveat. The caveat was that the planned accrual was 294 patients. The actual accrual was 141 patients, and the study was closed prematurely because we all felt if it was taking this long to accrue, obviously people were voting with their feet. They were uninterested in the TID radiotherapy arm. This couldn't really be interesting. Of course, we didn't know the results at that time, and so the study was closed prematurely. Of course, when the study data matured, we saw these numerical differences that matched the predicted delta, but did not reach statistical significance, primarily because we were 150 patients short of our accrual. So the lesson we learned from this was we failed to keep it simple. The TID radiotherapy was simply too complex for the vast majority of radiotherapy clinics, clinicians, and researchers to really conduct and put forward. In spite of survival data, complexity killed this concept. The second example I want to give you is about practicality. This is the NRG-BN001 trial, which closed early this year in 2023. This trial was designed to try and compare photon versus proton radiotherapy in patients with newly diagnosed glioblastoma. And intriguingly, the randomization was to the standard arm, 60 gray conventional radiotherapy with standard temozolomide, or the experimental arm, which was dose-intensified radiotherapy to 75 gray, with either protons or photons based on who you were as an institution. You would pre-declare yourself as a proton or a photon institution, and that's how you would treat patients. And we thought this was a pretty nifty way to get this trial going. This is going to fall in the category of keep it practical, as you will see in a minute. So the trial took off, and we launched the trial in early 2015. Within a year or more, a year and change, the photon arm had accrued the necessary 302 patients. Absolutely no problem. We got all the patients we needed on the photon arm. At that time, the proton arm was barely about 1/3 accrued. So although the photon arm completed accrual in 2016, The proton arm did not complete accrual until 2023, 6 years later. So obviously the problem here was quite obvious. We had failed to keep it practical. We had failed to recognize that when we launched the trial, there were only 6 proton centers that were credentialed to enroll patients to NRG oncology trial, whereas there were over 100 photon centers that could do that. And in addition to that, the nightmare of insurance approval for proton therapy, even though these patients were on a randomized trial, were unimaginably complex and things that we had not foreseen. So these practical things about insurance issues, about limited number of centers, were obvious problems that we had not foreseen. Fortunately, the trial has closed to accrual now, and we're awaiting maturation of the data to see what the results will be like. Let me now switch to some success stories. I'm going to start with the trial RTOG 0614. This was a trial that tested the concept of whole brain radiotherapy with or without memantine, a chemoprotector for cognitive toxicity. In fact, we demonstrated on this trial that cognitive function deterioration could be prevented by chemical modification. And we defined success using uncommon, unusual endpoints for that point in time, and that was neurocognitive testing. And we had very specific measures and test batteries that we developed specifically for trials of this nature. So we had thought through how success would be defined. We had thought through how we could measure it. And fortunately, the trial turned out to be positive. So everything fell in place. That's great. But when things fall in place, the question, of course, is what do you do next? So we went back and looked at how we had defined and measured success. We had done that using a battery of neurocognitive tests. And in particular, we identified that it was the Hopkins Verbal Learning Test, focusing on memory recall, especially delayed recall, that was critical in understanding how cranial radiotherapy affected cognitive function. But if we looked at functions like processing speed, for example, cranial radiotherapy did not affect this. Cranial radiotherapy did not affect executive functioning significantly either. So we could not simply develop a test battery and throw everything in it. We had to be selective about specific functional domains that are known to be affected by radiotherapy and design trials using those specific components in test batteries. That led to more success because success breeds success. Having shown that chemical protection for cognitive deterioration has a potential role, we investigated within a single-arm trial, RTOG 0933, whether dosimetric modification using hippocampal avoidance of the perihippocampal subventricular neuroprogenitor cells could result in memory protection. And this was a modest trial of 51 patients. And the comparison was a well-described historic control. Eventually, we ended up designing a target sample size of 102 patients, and the trial met the predicted hypothesized difference compared to the historic endpoint. Having recognized that chemical modification made a difference in a randomized trial, having demonstrated that dosimetric conformal avoidance of critical areas could potentially be of value, we were able to breed success upon success to launch NRG-CC001, which was a phase 3 randomized trial of whole brain radiotherapy in patients with brain metastases with memantine compared to hippocampal avoidance with memantine. And this particular trial now used both chemical and dosimetric modulation of neurocognitive function to detect an improvement in cognitive function. And in fact, we use that battery that I described to you, specifically focusing on time to cognitive failure. Cognitive function failure with whole brain radiotherapy at 6 months was presumed to occur in about 54% of patients. compared to 43% of the patients receiving hippocampal avoidance radiation. And we had presumed that this would require a little under 400 patients. And in fact, that's exactly what happened. We ended up showing success from this particular study. So clearly, the opportunity for successful trials is to allow one to build on the next trial. This is what that success looked like. Look at the project accrual in blue compared to the accrual that we actually achieved in real life in maroon. When a clinical trial is practical, when it's simple, when it's based on prior data that people have belief in, and they believe this can really change things for patients, accrual goes like gangbusters. We accrued at 16 patients a month and completed 2 years earlier than projected. And fortunately, the results bore out a positive outcome, resulting in a slew of subsequent trials testing hippocampal avoidance, proving the point that the best form of flattery is imitation. And so now we have CC003, looking at prophylactic cranial radiation for small cell lung cancer using hippocampal avoidance. We have CE.7, which is looking at hippocampal avoidant whole brain radiation for multiple brain mets. We have BN009, which is looking at a concept called brain velocity salvage using hippocampal avoidance. And we have CC009, which is definitive treatment of small cell lung cancer patients with brain metastasis with radiosurgery versus hippocampal avoidant whole brain radiation and memantine. So once you succeed, you get a slew of ideas that are born out of a successful trial. Once you fail, the idea is dead and buried forever. So what do we do if we fail? RTO0825 was a phase 3 randomized trial in glioblastoma that we launched with much gusto. This was a time when the treatment of glioblastoma was clearly revolutionized with the advent of bevacizumab. And bevacizumab was clearly going to make a huge difference in overall outcome. We were all convinced of this. So not only did we launch this trial, 0825, but the company in parallel launched the AVAGLIO trial. And both were very large trials, 600 plus patient randomized trials, over 1,200 patients in the 2 randomized trials. And the trials accrued like gangbusters, again, because people were convinced that bevacizumab will yield a survival advantage. And unfortunately, both trials fell flat on their face and did not succeed. And honestly, we were so convinced that both of these trials were going to work that we had not really genuinely planned for the question, what do I do if I fail? What is really intriguing is the failure of 0825 put a significant damper on large, massively sized randomized trials in the glioblastoma community and has changed the landscape of how we approve and move forward with glioblastoma trials. And performing boutique trials in well-selected subsets of patients where the testable hypothesis is definitely much more applicable than a uniform population across the board. In other words, marker-selected inclusion of patients has become the mantra in GBM trials. So the trial conclusions from 0825 were really to go look for subgroups that could benefit. We have not defined these subgroups as of yet in terms of supporting BEV or any other anti-angiogenic in newly diagnosed glioblastoma. And that perhaps is the lesson we learned from the failure and created better trials. So let me conclude here. Keep it simple, keep it practical. Know how to define and measure your success and build a pyramid if you succeed, because you'll be able to accrue patients and do lots of trials using that concept. But be prepared to think about failure on every trial that you design and think of what lessons you can learn from that. Thank you so much for giving me the time today. And I will stop here. Manmeet, I don't know if there's time for questions.
Thank you so much. And, I just presume anyone who's in neuro-oncology knows Vinesh Med as a chair of neuro-oncology or the brain tumor committee at NRG is, he showed the yeoman's work he and the group there has done. But Manesh is also a partner. He, serves as a deputy director of the Miami Cancer Institute. And, I've learned so much from him in my own life. But no, Manesh, that was amazing, wealth of information that you shared with us. And especially we have, young mid-career investigators in the room, and I'm sure they'll learn from your experience. Any questions for Dr. Mehta? We have a number of people online right now. I'm not seeing any questions. I know, Manesh, you have a family situation to attend to. Really deeply appreciate you logging in despite the, the family situation you were, dealing with. Wish you the best with that. And really, again, thank you for being a huge source of inspiration to me and several other clinical investigators in the field. And I look forward to continue to learn and collaborate with you.
Always a pleasure. Have fun, guys. Thank you.
Thank you so much. And we had to swap the order a little bit because of Dr. Mehta's, family situation. We're going to get back on order. And like I said earlier, the three speakers who are actually in the room will go last because the people on the East Coast are 3 hours ahead of us. So with that, after a great presentation from Dr. Mehta, you'll have a very interesting line of work from Dr. Nader Senai. Many of you know Dr. Senai and are aware of his work. And Nada has done some groundbreaking work in lessons from phase 0 clinical trials, the IV experience. He's really become the leader in the field in taking these drug surgery, drug trials to the highest level. So Nada, the floor is yours.
Thanks, Manmeet. Can you hear me and see my slides okay?
Yes, we can see your slides and we can also see you. Thanks.
Excellent. Well, I apologize for not being there in person. I had some surgical things that needed my attention today, but I'm honored to be part of this really well put together session. And thank you, Manmeet, and your colleagues for putting it together. I thought I would begin just by simply outlining the need for more tissue-based trials in our field, whether you want to call them phase zeros or window of opportunities. Whatever they are, PK/PD-driven studies are far in the minority historically in neuro-oncology, and I think we all recognize that we need more of them. Within the spectrum of clinical trialing, we have on one end a true microdosing phase 0, and the other end non-surgical trials. In the middle are studies that we alternatively call window of opportunity or phase 0, and at our program, we distinguish between these two on the basis of therapeutic intent. A phase 0 study being a surgical trial where there's drug exposure prior to tissue acquisition without therapeutic intent, and a window of opportunity being a surgical trial where the drug exposure preoperatively does have therapeutic intent. In between these two are a hybrid version of this that we've emphasized here at our program, which we internally call PK/PD triggered studies. And in these studies, patients receive drug exposure preoperatively without therapeutic intent, but based on a kind of real-time PK/PD analysis, they then go on to get therapeutic dosing of the drug only if they demonstrate a PK/PD response. We've had experience with a variety of paradigms that flirt with these concepts, starting with a pure phase 0 study. This was a protocol that we first initiated several years ago using a WEE1 inhibitor. Pure phase 0 studies are challenging in that they're non-therapeutic. They begin with screening and accrual, some exposure to the drug. And in this case, it was a single dose of the drug in one of two arms, what's called the dose escalation arm, and then another one called the time escalation arm, where we varied the interval of time between the dose and the operation. And this gives you a good spread of data for PK analysis. And ultimately, after that operation, the trial is over, the patient doesn't get drug anymore. And this is challenging to accrue to. Phase 01 studies obviously combine this with a therapeutic component, which makes it easier for patients to get on board with. This was a CDK4/6 inhibitor, an mTOR study that we recently reported. There's always some level of molecular screening that happens, and then exposure to the drugs, or in this case, a drug combination at 6 escalating pre-surgical doses, followed by tumor acquisition with blood and CSF as always. And then what we call a pharmacokinetic and dynamic trigger. So there's a PK/PD analysis that's done in real time with that patient's tumor to look at CDK4/6 and mTOR inhibition. And that's all done in a CAP-CLIA space that we've built out within our program. And then on the basis of that, within really days of the operation, you know whether the patient should go on to therapeutic dosing based on predetermined criteria. And then within that therapeutic arm or escalation, they then go through intrapatient dose escalation. A phase 02 is quite common and really just provides some statistical design to the phase 2 component of a phase 0 triggered study. This is a CDK4/6 inhibitor with an ERK inhibitor. Again, patients go through variable timing of dosing pre-surgically, and this is critical for most drugs because their understanding of achieving steady state in a drug is usually pretty approximate outside of humans and outside of the CNS. So you have to have a little bit of spread around what you think will be the optimal timing. And then in this study, there's a PK-driven trigger based on both of these agents having a unbound concentration of the drug in excess of 5-fold of the biochemical IC50, importantly measured within the non-enhancing component of the tumor. And then these patients go on to a formal Simon 2-stage design study. An expansion can always be added to a phase 0 study, and this is quite common as well. This is a PARP inhibitor combined with radiotherapy in the upfront setting for unmethylated patients. And again, these patients go through a pre-surgical exposure of the drug for 3 days, a PK-driven trigger, and then go on to have drug plus radiotherapy in the absence of Temodar when they're unmethylated. And so this can be quite a nice protocol to assemble quickly and to explore whether there's a clinical signal with the drug. One of the lessons we've learned from these types of experiences is the importance of tumor pharmacokinetics and how it really needs to be central to any planning around drug development. There's many examples of this. I think a nice one is the infigratinib multi-center phase 2 study, which is a really well-designed study looking to target FGFR aberrations and recurrent gliomas. And as many phase 2 studies that we've seen, there's a small population of patients that demonstrate what appears to be a clinical response. And then, of course, there's a lot of post-hoc analysis focused on the biology of the tumors in those patients and how they may be related to this clinical response. What's often missing, though, in this kind of assessment and planning is attention to the actual PK performance of the drug. And so here we have a phase 0 study that we undertook with that same drug. And what you see on the panel on the left in the red bars are the actual PK concentrations, the unbound concentrations of infigratinib in non-enhancing tumor for 3 patients. I've circled them there in red. And then in the upper panel, what you see are the PD readouts for these 3 patients, looking at the MAPK pathway, looking at MIB1 and cleaved caspase-3. And you see that each patient's performance varies according to the amount of drug that actually entered that patient's tumor. Patient 1 did best in terms of tumor concentration and PD analysis, and then was put on the phase 2 component of the study and ultimately recurred, and at the time of recurrence had lost the FGFR TAC3 fusion, which was the criteria for entry into this particular trial. So this really emphasized to us the importance of looking at tumor PK at an individual level. And this challenge of PK variability is compounded in the setting of drug combinations. Here's a CDK4/6 inhibitor plus ERK inhibitor phase 02 trial. And what you see is each of these vertical bars is an individual patient with their unbound drug concentration in non-enhancing tumor relative to this horizontal dotted line, which is our threshold for an adequate PK response, 5-fold the biochemical IC50 of the drug. And so some of these patients simply don't meet that criteria, although there are many others that do, and the median numbers certainly do. For drug number 2, it's a similar story. Many patients don't meet that criteria and others do. So if you put these performances together for these individual patients, it really makes it quite challenging for 2 drugs to perform well in an individual patient consistently. One of the other challenges, I think, within our field is when we use other methods to assess PK performance of a drug. And I think the operatic study is a good example of this. Here you had a study using a PARP inhibitor, olaparib, and recurrent GBM. There were 3 doses of the drug, and they measured total tumor concentration of the drug in tumor tissue. Now, total drug concentration is not a very good approximation of the pharmacologically relevant fraction of the drug, but using this methodology, they then targeted what they termed as the core and the margin of the tumor based on intraoperative tumor fluorescence. And this, again, has some variability to it. Ultimately, this led them to conclude that the drug was brain penetrant, that the total drug concentrations were quite high, which is true. But we then performed a similar analysis in a phase 0 trial where we compared pemiparib to olaparib. And in this trial, we had an arm where the olaparib drug was, again, distributed pre-surgically at 2 different time cohorts, used a intra-study PK trigger analysis, and then expanded patients based upon their PK performance to drug plus radiation. Ultimately, what we learned about olaparib is that when you measure its unbound drug concentrations and you measure it in non-enhancing tumor, you can see these yellow vertical bars. Only 1 patient in 5 actually exceeded the preset threshold. And in fact, the median numbers for unbound drug were barely the biochemical IC50 of the agent. So our assessment would be the opposite, that this is not a brain penetrant agent and actually shouldn't be the subject of additional studies within neuro-oncology. Pharmacodynamics, of course, always trumps pharmacokinetics. And this is important in understanding why things fail as much as it is in understanding which drugs are succeeding. Here you have the swim lanes of the CDK4/6 ERK inhibitor study, which are unremarkable for these 7 patients and show early progression in all of them. And here you have the PD analysis for these same patients looking at CDK4/6 pathway activity, which was significantly decreased comparing baseline to surgical tissues, and then phospho-RSK, which is a readout for ERK, and then the proliferative index. What's important to see here is that when we look at baseline tissue in this study, we're often looking at archival tissue, which can be many months preceding the actual phase 0 study. And really, it emphasizes the importance of pre-treatment biopsies. And so we had several patients with pre-treatment biopsies performed. And here you see the true performance of these agents in the setting of phospho-RB expression, where there was, for these 3 patients, good evidence of suppression, and phospho-RSK, where we didn't see that. And so in a study like this, it leads you to ask several questions. Is the ERK inhibitor performing adequately when it gets in? And is phospho-RSK the right readout for this molecule inhibitor? And there are other candidates that could be explored. Choosing the right readout for a tumor PD endpoint is one of the most important things in study design. This is an ATM inhibitor that we have undergoing a phase 0/2 with XRT. This is a study that looks at basically a molecule suppressing or targeting ATM phosphorylation, and it's really working through RAD50 phosphorylation. We know a lot about RAD50. We know exactly how it works in the setting of double-strand DNA breaks, in the setting of radiation. We know that it mediates downstream processes related to S phase and DNA repair. So this is a molecule that is a direct target of ATM itself, which is targeted by our drug. It's measurable and quantifiable. And importantly, it has metrics to measure which are durable and work in a variety of tissue settings. Once you identify this candidate PD endpoint, then you have to do some homework in interrogating whether this is truly an important relationship for drug mechanism. So here we have ex vivo GBM tissue with sequentially increasing ex vivo radiation, showing the upregulation of RAD50 phosphorylation. And then we have a rescue, if you will, of this effect in the setting of this AstraZeneca targeted inhibitor. So this is all a validation that this is the right PD endpoint for this study. I've mentioned several ways in which you can assess tissue for PD analysis. Probably one of the best ways is a pre-treatment biopsy. And we simply just don't do enough of this in our field. And I think as a neurosurgeon, we've been working hard to change this reality. This is a low-risk procedure. It's ubiquitously available for brain tumor patients. It could be done as an outpatient. It's cost-effective. And it frankly needs to be used in more scenarios than it is. Patients that present to the emergency room like this one with suspect histories and differentials of abscesses versus GBM, for example, can be easily biopsied without being taken to resection. Patients we see every day in tumor board with mixed treatment kind of radiographic imaging features like this one on perfusion can also be easily biopsied and avoid the hemming and hawing of repeat scans and additional imaging. And we've reported recently at a neurosurgical meeting the feasibility of doing outpatient needle biopsies, the cost efficiency, and importantly, the fact that payers, whether they're commercial or non-commercial, accept this as a acceptable and important part of standard of care. Now, there are alternatives to this, and probably the most robust way to have an alternative is, for example, what Ingo Mellinghoff and colleagues did with their IDH inhibitors by basically taking a separate group of patients and demonstrating robustly that there is a baseline to the value that you're measuring, in this case, 2-HG. And so this can be done for certain biomolecules that do follow these criteria and don't migrate a lot from patient to patient. And then, of course, the most common way that is used currently is matched archival tissue, which we've done as well, and frankly has a lot of limitations, can give you signals that sometimes don't hold up when you're looking at pretreatment biopsies. As Manmeet knows, tumor PD is not a static target. The Depitux study, for example, was a good example of this, where the ADC targeted EGFR, and what we saw over time and what Manmeet and colleagues have shown is that there's a migration of that profile, and tumors adapt, and those PD endpoints can disappear on you. This is one of the fundamental problems of tissue-based studies today, is that you're looking at really a single time point. Once these patients are identified, exposed to therapy, and clinically recur, we're really sampling things at a single time point and then hoping that we're going to have other opportunities to reanalyze the tissue. But in fact, very few phase 0 trial patients in our experience go on to re-resection because they have advanced disease. So this really creates the need for some sort of longitudinal ability to surveil PD and frankly, tumor biology. At our program, we've really emphasized expanding a platform using CSF liquid biopsy, inserting in most phase 0 trial patients an intracavitary Ommaya. And Ingo Mellinghoff and Alexandra Miller have shown, as have others, that there can be good concordance with CSF and tumor biology. And importantly, you can see the generation of new adaptive resistance mechanisms in tumors, like this patient that lost their EGFR amplification and supplanted it with PDGFR. Wouldn't that be useful to know in the setting of EGFR ADC? And this is a protocol that we have underway with one of our residents, Shrita Fury. I'll just end by saying none of this type of strategy works in a conventional space. There needs to be program specialization. That begins at the laboratory, it ends in the clinic. Our laboratories really focus on experimental paradigms that inform the PK/PD-driven clinical trials that they're leading towards. So this includes performing in silico pharmacology on various drugs of interest and targets of interest, and then performing in vitro pharmacodynamics, having cell viability assays that test the spectrum of tumors so that you're approximating the spectrum of tumors you see in patients, and focusing on interspecies pharmacology so that your preclinical data is not misleading the PK performance you expect in humans. Similarly, performing in vivo pharmacokinetics in your animal modeling and in vivo pharmacodynamics, also tuning some of the assays so that you're prepared for your phase 0 trial, and of course, looking for some survival signal. The story arc I show you here is for an HDAC inhibitor, quizzinostat, which was developed in one of our laboratories led by Shwetal Mehta and now is entering a phase 0 trial. There's a cultural adaptation that has to happen with respect to the operating room and the perioperative staff. And this really means bringing them into the fold early and educating, making them part of the surgical trialing team, and engaging patients because of the cultural aspect to patient socialization to these concepts. These engagements have to happen preoperatively. So we have navigators embedded in a variety of specialty clinics, and we have a lot of pre-screening activities and clinician family educations. And frankly, there has to be a lot of interplay between our clinicians and scientists. So we kind of call this at our program a single cell mentality. We have laboratory scientists that are really capable and comfortable with writing and leading protocol development. And we have clinicians who are equally capable of analyzing and interpreting laboratory data. And of course, there's a lot of specimens and data flying around in these types of programs, and having the infrastructure to balance what's happening within the preclinical labs, in our case, CAP-CLIA, PK/PD labs, and then the clinical operations. And one of the features of our program that not everyone realizes is that the Ivy Center itself is independent of any single medical center or hospital system. We're a separate 501c3, and as such, we've been able to kind of vertically integrate everything that's involved in clinical trialing in this population, from fundraising to contracting to regulatory. And so this makes everything really very simple for our industry partners and much faster than ordinary. So I'll end by just reemphasizing that drug development really should be led by tumor PK analysis and anticipation. Tumor PD is oftentimes the most important endpoint to emphasize when you're analyzing a drug's performance. Tissue-based trialing itself really needs to happen in an adapted environment, and obviously there has to be a cultural shift within that environment. And in our experience, these PK/PD triggered phase 0 trials are really very valuable, because what they do is they give you a biological context to any individual clinical result, positive or negative. I'm really here representing the 50+ employees of the Ivy Brain Tumor Center who are behind all of this work. And on their behalf, I thank you all for your time and attention.
Thank you, Nader. Really a great talk and overview. Any questions for Nader? So Ali Raza has one. So Ali, if you want to speak on the mic.
Hi, hi, Dr. Sanai. Great
Hi.
talk as usual. I always learn so much from you. One question, in one of the trials you mentioned, you were collecting CSF at day 5. Is that different from what you're collecting through the Ommaya reservoir? Because you mentioned that's intercavitary.
No, it is different. So that day 5 is the actual surgical timing. And at that time you collect CSF, so that's your baseline. And then we typically bring patients back once a month for the intracavitary Ommaya draw. And that happens prospectively afterwards.
Okay, so and the tip of the Ommaya is in the brain tumor resection cavity. So by then the fluid has circulated and the tumor is in theory shedding. Was that correct?
That's correct. And there's certainly some ebbs and flows of the tumor genetic material that we're starting to learn more about. But yeah, by 4 weeks out, you've kind of gone through the immediate perioperative phase.
Thank you so much.
Thank you so much, Nader. Again, thank you for sharing really this phenomenal work that you've created in the last decade or so. And I remember having those talks with you more than 10 years back. So can you share with some of the young investigators that we have in the room, what would be your guidance to them? And because what you've created is really unique. Because and in some ways it's fine because it's mostly niche trials. But if we wanted to bring these things to cooperative groups, are there some pearls that you would share with people? What does it take to get to the level that you have at?
Yeah, to be honest, I think it's quite difficult to do this in a cooperative group because what you know is that every site's operative infrastructure varies and their kind of perioperative culture varies. So I think, the first thing is, what Roy Patchell told me a decade ago when I first started here, which is if you're going to do work in a cooperative group, make sure you're doing it with your friends, because there has to be a lot of give and take in aligning your practices. The second is that, I think that these studies can be quite elaborate if you let them be, but as Manesh kind of counseled us, the simpler the better. There's always this, very, very natural desire to create a lot of correlative analyses and endpoints, exploratory analyses and endpoints in these studies. And I think, our experience is keep it simple, and especially when you're running it across multiple sites, limit the number of endpoints and limit the number of permutations and study arms.
No, thank you. So thanks again for eloquent talks. With that, we are going to move on to Dr. Patrick Wen, who's also joining us virtually. Patrick has a concept on FGFR attack, gene fusion inhibitors in glioblastoma. Patrick, you can share your screen and whenever you're ready. And while Patrick's pulling up his slides, again, I presume everyone knows Patrick, but Dr. Wen serves as the Director of Neuro-Oncology at the Dana-Farber Cancer Institute. And again, I can just speak for myself, but can speak for several people. My little trivia is I actually got into neuro-oncology after talking to Patrick when he was chairing the neuro-oncology education day at the SNO meeting in Vegas. And he was so giving. And he's also been a great source of inspiration for me and countless other people in neuro-oncology. Patrick, we can see your slides. So whenever you're ready.
Okay, great. Thanks so much. So this is just a very short concept. It came out of, I was talking to Antonio Iavaroni at a recent meeting, and this was something that he was very interested in. So it's just a small concept to see if it's feasible and if there's interest. So it's a proposal for a randomized phase 2 trial of erdafitinib, an FGFR inhibitor in newly diagnosed unmethylated MGMT GBM with FGFR TAC fusions. So as you're all aware, FGFR TAC fusions occur in about 3% of glioblastoma. So this is a small and not an easy population to work with. These fusions are oncogenic, and Antonio Iavaroni has published a series of studies supporting this. And he has also shown that these tumors with these fusions are sensitive to FGFR inhibitor. This is with the Johnson compound that was the precursor to erdafitinib. This shows the tumor size decrease with treatment. And so, as you know, erdafitinib has been tested in a variety of cancers. It's an FGFR 1 to 4 inhibitor. And those patients here in gray with the fusions appear to be particularly sensitive. This drug has gone on to be FDA approved for locally advanced or metastatic urothelial carcinoma with FGFR3 or FGFR2 mutations and alterations. And then more recently at last year's ASCO, there was preliminary results from the Ragnar trial. This was a large study looking at the effects of erdafitinib on a variety of tumors. The response rate by independent review was 29.2%, and both mutations and fusions were sensitive. And the median duration of response was about 7 months. There were 29 patients with high-grade gliomas, and the response rate was 20.7 months. There's also a companion assay that has been developed that's FDA approved for looking for these fusions. So these fusions are clonal and they're present in recurrent tumors. And so there is a plan, or maybe it's already started, trial that Macarena de la Fuentes is leading, looking at erdafitinib in recurrent GBM. But one of the problems in recurrent GBM is, even though these tumors usually retain the FGFR TAC fusion, there's upregulation of oxidative phosphorylation pathways. And so, just targeting the fusions may not be sufficient. And I think Antonio Iavaroni feels that the best chance for this type of drug would be in first line, where the oxidative phosphorylation mechanisms are less in play. So this sort of falls on the recent success of targeted therapies in first line. As most of you know, Eric Buffet has looked at dabrafenib and trametinib in BRAF V600E mutated low-grade gliomas in children. And he did a randomized study comparing the targeted therapy with standard chemotherapy and showed a significantly increased response rate with the targeted therapy compared to standard chemotherapy and increased progression-free survival. And this has led to the approval by the FDA a month or two ago for this combination in first line. And they have a paper that's in revision that almost certainly will get accepted and published soon. So this is just a very rough concept because, you know, one of the issues is whether this is even feasible. So the idea is you would get a newly diagnosed GBM patients with unmethylated MGMT. You genotype these patients. During this time, they would go through radiation with concomitant temozolomide. And then after completion of the radiotherapy, by which time you would have your genotyping, one of the arms could be that in the small numbers of patients that have the fusion, they would enroll into a trial where they receive either standard temozolomide chemotherapy. And the question of whether you allow Optune is it's something that can be debated. And then the other arm, you would have erdafitinib. And again, plus or minus Optune. And then you would look at overall survival. In theory, since you're genotyping these patients, you would identify other targets. And so potentially you could find the BRAF V600E mutants, and you could have another trial or another arm. And then there may be other targets as well that you would look into. The primary endpoint would be survival. Secondary endpoints would be ORR. And the other endpoints are listed here, which are fairly standard. So I haven't, this is just a really rough statistical plan, but you know, potentially you could have 100 patients randomized 1-to-1, and this would have an 80% power to look at an increase in survival from 14 months to 24 months. You could, as in Eric Buffet's trial, do a 2-to-1 randomization, so the power would be somewhat reduced. So this is just to see whether you think it's feasible. I mean, it's so uncommon. Maybe it's not a feasible trial. But I think it's the kind of thing that if you actually could do it, it might be positive. Similarly, if you could do a trial of targeting BRAF V600E in first line, that's likely to be positive. But again, it's hard to do these trials because of the patient number. So I'll stop there and see if anybody has questions.
Thanks so much, Patrick. Questions for Patrick? People online? Oh, okay. Vaishak has a question. Vaishak, you want to speak on the microphone?
Patrick, I learn a lot every time I hear you talk. I have a couple of questions. One is, why only FGFR TAC fusion and not other FGFR alterations, as in the infigratinib trial?
Yeah, no, you could have mutations as well.
And is this drug a better drug than the infigratinib drug that is being studied?
I think Nader has shown that the other one isn't very good. This one, at least clinically, there's 21% response in high-grade gliomas. I don't know whether the brain penetration has been formally studied. This one also gets, it's also FDA approved. The other one is the Taiho drug, TAS. I think it used to be TAS 120. It's got a real name now. That's also being looked at for brain tumors by John de Groot, but I don't know if that one gets it any better.
Yeah, I think
Thank you.
very appropriate point, Vaishak. And I think we actually have a study of pemigatinib right now as well, and I actually been involved with that. And we are looking actually beyond just the fusions, we are actually looking at mutations. What I can just tell you is it's actually open at like 60 sites globally, and we have struggled. I'm not put on a single patient. I serve as the chair of the steering committee. So I think, Patrick, this is a great concept. And if you, so we would love to explore this more through the SWOG mechanism. So I'll get back to you. We'll talk to the statisticians. I think the critical component, as you spoke about, is even if you're looking at 100 patients or their whereabouts, you pretty much, unless if you change it to mutation, which numbers goes up to like 5 or 6%. If you stick at 3%, then we'll need to profile 3,000 glioblastomas. So pretty much we'll need to be all the cooperative groups coming together, and at least for 3 years or so, if not more. Just if I remember the RTOG 8205 numbers, where we, as Banesh was alluding, we enrolled like gangbusters. And after that, the numbers have never been the same. But no, I think clearly exceptional work from Antonio Varone. There is definitely science, and I think the concept is very intriguing. So I'll at least discuss it with the SWOG statisticians and get back to you. But I think no matter which cooperative group you go through, will need support from all the others, because this can only be pulled off as an intergroup study. It cannot be pulled up in any cooperative group.
Manmeet, can I make a quick comment?
Oh, please do.
Patrick, so I really love the concept, and of course, we follow Antonio's work. I just wanted to show you an internal analysis we did when we started our phase 0 of infigratinib. And I can share this with everyone because it was for the company that developed infigratinib, which has since folded. But we typically, when we look at a target like FGFR, we look at everything available and try to do a preclinical and in silico analysis. So here are the 7 FGFR inhibitors that are, at the time of this analysis, were in development. In the yellow bars, what you see is their IC50. And then in the blue bar, the blue landscape, what you see is the unbound concentration of the drug. And so if you look at these agents, and I'll just skip to this slide, from the standpoint of unbound drug concentration, and this is all work that we did internally with animals, probably the ones that really stood out for us were the Lilly agent, the TAS-120, as you mentioned, infigratinib, and there was an AstraZeneca agent, which I don't think is in development anymore. So this might be something to consider when you're thinking about which agent to use for this proposed study. And I'll send this over to you guys later so you can have that in case it's of value.
Oh, that's great. Yeah, the particular drug is, it's completely open because we haven't approached anybody. And also, if anybody's interested in doing this, they're welcome to take the lead on this. I'm just kind of the middleman here, seeing if anybody's interested in this general concept.
I think Andrew Brenner has a comment.
Oh, I was just going to mention, I think that the way you showed it, Patrick, in terms of including other agents for other targets as a match type trial might work. If we have other agents, the problem is that it's really hard to open cooperative group studies for just a couple patients. It's because financially cooperative group studies are very challenging. Yeah. I have to enroll at least 5 patients in a year for us to break even. And unless we have multiple arms with multiple, and I can't think of that many, and we kind of already have some, reasonable data with dabrafenib and trametinib. If there's a way to maybe come up with 3 or 4 arms, I could see where it could be feasible, but we'd have to kind of really think about the logistics of it from a cancer center perspective, where you really have to break even. And to break even, it's really going to be like 5 patients a year. And I've had a lot of studies that I've really liked and I really wanted to succeed, but then have to close them soon after opening them because we just can't support such low accrual.
Yeah, no, you're absolutely right. I mean, the other arm would be fusions, which are also super rare. Those are the three that, that has some data. The other problem, in the ideal world, you would share a common control arm to reduce patient numbers. And I guess we don't really know for sure whether the outcome of these patients is the same when they have a TAC fusion or a BRAF mutation. There's data out there, but it's a little bit all over the place.
No, I think that's a very eloquent point, Patrick. Clearly, we learned that the hard way through the EGFR V3 variant Rendo's trial. And also there is some data, again, as you said, all over the place, but there's definitely some data that the FGFR tag gene fusion may have better survival. So there have been some, papers alluding to that, and which makes, unfortunately, doing such biomarker-driven studies extremely challenging in glioblastoma compared to lung cancer, where they've got ALK and 4%, and they can run studies, and now they have like 6 inhibitors which are approved, and every time they develop a new inhibitor, it's much better than the previous one. But no, something to definitely consider. So we will follow up with you on that, Patrick. Thank you so much for bringing this concept forward and being a great mentor to numerous of us. Thanks again. With that,
Thanks
next
so
we're going
much.
to move on to Dr. Craig Horbinski, who's a leading neuropathologist, as you know, in the country. He is at Northwestern University and has done some really cool work in predicting venous thromboembolism in adult type diffuse glioma patients, and he's going to share with us some of his work.
Hello, everybody. My apologies for not having been there in person, but actually I was working all day on a clinical trial. Oops, my apologies. I was working all day on a clinical trial associated with this project, which explains my frazzled look, frankly, because I've been at this computer for 14 straight hours now. So we published recently a study, and I don't have the time to get into the backstory of this, although it is, at least in my estimation, an interesting backstory of how on earth I got involved in thromboembolism and gliomas, since that wasn't my training or interest up front. But nonetheless, published this just relatively recently here in Blood. And one of the things that we found, well, there's a lot of things we found in that paper, and if you're at all interested, I encourage you to pursue it. But it is actually really interesting. I suppose in some sense, the quintessential example of patient-based observations being brought into the laboratory and then hopefully translated into better clinical practice. One of the things discoveries I made somewhat serendipitously was that the IDH mutant gliomas really didn't contain intratumoral microthrombi nearly to the same extent as IDH wild-type glioblastomas did. And that was like going on 10 years now, I made that discovery. Like, again, just pure accident by virtue of looking at all these tissues. Well, to hyper summarize a lot of data, we were able to confirm that, and others have confirmed that as well, that IDH mutant oligodendrogliomas and astrocytomas, when you follow them over a long enough period of time, have a relatively low rate of venous thromboembolism, but IDH wild-type glioblastomas really do produce a lot of venous thromboemboli over time. And this is a non-trivial issue. I mean, some of these patients will ultimately die of the thromboemboli before the cancer itself gets them. And even those who survive, they're debilitated if it becomes a big enough pulmonary embolism, and they'll end up having a significantly shortened survival. The catch is we haven't really known to date which patients specifically to target, who's at highest risk. So the study I'm showing you here that was published in Blood is trying to address, at least somewhat, that knowledge gap. Tissue factor, which is as strongly associated with glioblastomas because as it turns out, IDH wild-type gliomas really hypermethylate and suppress the expression of tissue factor. I mean, really, it's one of the most hypermethylated and downregulated genes in the entire IDH mutant genome for reasons nobody knows. But nonetheless, tissue factor immunohistochemical expression in the tumor itself tends to be a lot higher in IDH wild-type glioblastomas compared to their mutant counterparts. And that also, as on the right panel, strongly correlates with increased risk of venous thromboembolism over time. Likewise, circulating tissue factor expression correlates with circulating tissue factor microvesicle activity. So that's blood draws taken at the time of initial surgery, right before the first incision. And what I'll call to attention is the very highest levels of tissue factor microvesicle activity, greater than 2.0 picograms per mil, because other people in other cancers have indicated that threshold, once you get beyond that threshold, that patient is at extraordinarily high risk of a venous thromboembolism. And that indeed turned out to be the case in our glioma cohort. There weren't a lot of patients who had that up front at the time of initial surgery, but those who did, boy, they really blew up into venous thromboemboli very, very, very quickly, within just a few weeks, in most cases, after surgery, as you can see there. Likewise, D-dimers, those are another circulating blood marker of thromboembolism. And IDH wild-type glioblastomas, on average, tend to have a very, very high level of D-dimers compared to their mutant counterparts, especially the very highest levels of D-dimers, 2,000 nanograms per ml or higher. And that also correlated with very rapid progression to venous thromboembolism post-surgery. So and then on top of all that, what we did was we took a very large cohort of patients with adult type diffuse gliomas from Northwestern, Duke, and UCLA, made sure that they were all indeed gliomas, by the current 2021 WHO standards by molecular diagnostics, and worked through a discovery cohort at Northwestern and then validation cohorts at UCLA and Duke, distilling an incredibly large number of variables, well over 100 variables, distilled down to 10 variables that, as best we could determine, really drive VTE risk in these glioma patients. And the reason we did this, of course, is because while the coronary risk score is very, very good at predicting VTE risk in cancer patients who with other cancers outside the brain, glioma patients, no predictive algorithm currently exists. Well, this one addresses that deficiency, because what we found is there's 7 risk factors that are positively associated with a venous thromboembolism. Biggest one being the history of VTE, but hypertension, asthma, white blood cell count, WHO grade, patient age in years, and body mass index. And the neat thing about this analysis, which was produced by our extraordinary biostatistician, Kirsten Bell-Burdette, it's not just like an arbitrary cutoff like you get in the Cox proportional hazards modeling. This is lasso event modeling, meaning every increased patient age in years adds additional risk. So every increase in body mass index adds additional risk. Every increase in glioma grade adds additional risk. Conversely, the negative risk factors were MGMT promoter methylation, which of course is binary, hypothyroidism, and IDH mutation, which, by the way, is the only molecular marker in any cancer that we know of that actually suppresses VTE risk. And so this was summarized in the graphical abstract for that blood study. 7 positive risk factors for VTEs, 3 negative risk factors for VTE. And we integrated it into a prediction app that is online. Now, I don't know that I'm going to be able to, I'm going to try to share it with you. Actually, in the interest of time, I encourage you to, the web link is embedded in that blood paper, but here would be an example. So let's say you enter through radio buttons, the patient has history of hypertension, hypothyroidism, asthma, VT, all that business. And you put all that into a predictive algorithm. At the very top, you get estimated VTE risk at 1, 3, 6, and 12 months. So for this particular patient, the risk is relatively modest. But you can change the parameters as you see, just play around with it and see how the risk changes with each different parameter. And we're trying to leverage this now into a prospective clinical trial where we use this predictive algorithm to stratify high versus low risk glioma patients and say, okay, for the high risk glioma patients, we're going to randomize them into getting a direct oral anticoagulant, a DOAC, in this case, apixaban, and just see how they do. Does apixaban lower their risk compared to the control patients who are observed? And then also track in all patients serial blood draws and just say, okay, the tissue factor microvesicle activity that we saw that's clearly being produced by the cancer, as well as D-dimers, do they add any additional predictive information? In other words, if you track somebody over time and you find that their levels are very, very low, all for during adjuvant therapy, so on and so forth, and then maybe at some point later during their disease process, their levels spike. Does that then correlate with an imminent venous thromboembolic event? And if it does, then that could also inform whether or not the patient should be put on antithrombotic prophylaxis. So I'm trying to be parsimonious as concerns time, because of course it's late and everybody's is working on lots of things here, and there's lots of good data being presented tonight. But I would say if you can instantiate anything that I've said tonight, IDH mutation really does suppress tissue factor expression. We've actually proven that in the laboratory by methylation, by promoter methylation. That seems to be a very key element of reduced VTE risk in those glioma patients. So IDH mutant glioma patients are at substantially reduced risk. And that actually explains a lot of the old literature on patients, like, elderly patients and grade 4 tumors being the greatest risk for thrombosis. Much of that risk, as it turns out, is because of the IDH mutation, because that's less likely in older patients and grade 4 gliomas. Furthermore, this online VTE risk calculator, which is the very first risk calculator ever specifically designed for glioma patients, that may actually help identify patients and stratify them as concerns whether or not they should be getting antithrombotic prophylaxis or not. And then finally, on top of all that, it may be worthwhile, at least in some patients, we're trying to figure that out now, that's the clinical trial I've been working on, is regular testing for, like monthly testing for tissue factor and D-dimer levels, very straightforward assays in the blood. Does that add additional value? So if you track somebody who potentially perhaps is at high risk or somebody for whatever reason you're concerned, if you track those levels on a monthly basis or a bi-monthly basis, does that actually help predict who is at imminent risk of VTE? Because the patients that we had the single blood draw at the time of initial diagnosis, those patients with the very highest levels of either tissue factor or D-dimers, a substantial proportion of those patients ended up developing VTE within just a couple of weeks after surgery. So we're trying to see if that extends into the post-operative outpatient setting. So lots of people to thank. There's tremendous group that I've got currently, as well as prior people who've helped with this research. Lots of people to thank, collaborator as concerns collaborations, and fortunate to have had a number of support grants from the NIH and the Brain Tumor Institute. If you're at all interested in, I'm sorry, I plug this every time I give a talk. If you're interested in any of the neuropathology that I publish or tweet out, especially with interesting molecular cases, by all means, follow me on Twitter, and I'll take any questions.
Thank you so much, Craig. I think Pilar has a question.
Yes. Thank you so much, and congratulations on this new data. I think it's very interesting. In your experience and following the data along, have you noticed, or is there a chance that the tissue factor and the dimer, when you start seeing that is normal, and then rises, could that be a surrogate of tumor, either the tumor is returning or when it's high on a, at the baseline, the patient is going to have a more aggressive course?
Oh, absolutely. In fact, that's a terrific question. So a couple of things that we're trying to do with this trial is first of all, we're going to track them as concerns, exactly what you said. If the levels spike, does that portend not just imminent VTE, but does that also portend tumor recurrence and or progression? So that's something we're trying to track now. The other thing is does this portend a worse prognosis? Well, we know that in a lot of cancers, including gliomas, the higher the level of tissue factor expression in the tumor at the time of original diagnosis, the worse the patient's prognosis is. And I didn't have time to show all that data in the blood paper. I encourage you to read it if you can. But we showed definitively that a lot of IDH wild-type glioma patients or glioblastoma patients have a very heavy levels of tissue factor expression in the actual tumor. But it's virtually non-existent in the IDH mutant patients. So we have an unrelated study that we published. It's a related study that we published a few years ago. We actually showed that if you artificially induce expression of tissue factor in IDH mutant gliomas, you actually do make them more aggressive. So we think that the suppression of tissue factor in IDH mutant gliomas is one reason why they are less aggressive than their wild-type counterparts.
Thank you so much, Craig, for addressing this important issue for our patients. With that, we'll continue our theme of online speakers first. And next, I would like to invite Dr. Tony Wang, who is a professor at Columbia University, and he has a concept of phase 2 study of atezolizumab and tocilizumab and radiation in patients with newly diagnosed MGMT unmethylated glioblastoma.
Okay, can you see my screen, Manmeet?
Yeah, we can see you and see your screen. Thanks.
Okay, thank you so much. Sorry again. And I'm sorry I couldn't be there. I literally was just spent 4 days doing oral board exams this past 4 days. So I just, it wasn't really good for me to travel. But so I presented this concept before, and thanks again for the opportunity to present this. I presented this concept at SWOG, and thanks for the folks who are on the committee and the working group who've provided a lot of feedback. So I've made some changes to this over time. So to make it short, this is a phase 2 study of atezolizumab and tocilizumab with radiotherapy in patients with newly diagnosed MGMT unmethylated glioblastoma. These are my disclosures, and they're electronically available. So to this group, I think most of us already know this pretty well, so I'm going to kind of move this really quickly, but GBM is the most common primary brain tumor. It's the most aggressive. And again, from our classic randomized trials, we know that median overall survival for these patients is about 14.6 months. This is not including the use of TTFs. And again, most of the benefits of temozolomide is driven mainly from subgroups with methylated MGMT promoters. MGMT methylation is prognostic for median overall survival. So if you have it, about a third of patients have that, there's an 18-month median overall survival versus 12 months in those who have unmethylated MGMT. And it's also predictive. Basically, with the benefit from temozolomide, we know that those patients who have methylated MGMT have increased median overall survival by about 8 months. And then those who don't have that, with unmethylated MGMT, median survival increases usually less than 1 month. So again, just in the interest of time, I'm just kind of moving along, but this is a study actually Northwestern looking at TCGA cohort using RNA sequencing and microarray data, demonstrating that there's the interleukin 6 expression levels associated with worse overall survival in gliomas. And I have presented this before, and again to this group. So please stop if you have any questions about that. This is also a study, I believe, from Penn looking at anti-IL-6 therapies that's been shown to reduce burdens of M2, CD206 macrophages, particularly CB11B cells. And this is, again, from the same paper looking at anti-IL-6
microantibodies that improve survival in these genetically orthotopic GBM murine models. The combination of IL-6 versus anti-CSF1. Again, this is again a paper from Lamano. Using anti-IL-6 therapy, it's been shown to reduce CD68 myeloid cell infiltration, increase CD8 positive T cell infiltration. Both the IL-6 signaling in GBM reduces local and systemic myeloid-driven immunosuppression and enhances immune-mediated anti-tumor responses against GBMs. So this is kind of the meat of that paper, looking at the combination of anti-IL-6 and anti-PD-1 acting synergistically in GBM C57BL6 mice, where Lamano looked at both monotherapy as well as combination therapy of anti-IL-6 and anti-PD-1s. They found was both reduction in tumor volume as well as improved survival with combination versus monotherapy. And for those who aren't familiar, tocilizumab, this is a study from a group in China using IL-6 receptor blockade by toci, demonstrating certain levels of therapeutic efficacy in xenograft models in vivo. And again, just showing again from the paper from Lamano, looking at the combination of IL-6 PD-1 having better survival versus the monotherapy alone, suggesting that maybe the monotherapy is just not enough. And that's kind of corroborated with some of the prior checkmate trials, monotherapies for GBMs. This is an ongoing trial for NRG. This is NRG-BN010 from Stephen Bagley at Penn. Basically, it's a phase 2 trial of atezolizumab and tocilizumab with reirradiation for patients that have first recurrence of GBM. And they're stratified first by surgical resectability. For those who are resectable, and from Tim Clause's paper, they would undergo neoadjuvant atezo tocilizumab or just atezo by itself, followed by fractionated radiosurgery, and then surgical resection, and then adjuvant immunotherapy after that. Or if they're unresectable, then these patients would still get neoadjuvant toci-atezo followed by FSRT, and then adjuvant toci-atezolizumab. So the question that we presented here at this meeting was to propose a phase 2 trial for newly diagnosed GBMs who are unmethylated MGMT to get combination atezolizumab and tocilizumab with radiation therapy. The radiation therapy would be standard of 60-30, and tocilizumab is consistent with what was used in the NRG-BN010 trial. The primary endpoint is 1-year overall survival. And our group predict a 1-year overall survival benefit about 70%. And that required 37 patients using 80% power at alpha 0.05. And we think that would take about a year and a half, 2 years for complete accrual with a follow-up about 2 years. Secondary endpoints would be to evaluate safety of combination atezolizumab and tocilizumab, which have been demonstrated in other prior primary disease sites, including prostate cancers, and then progression-free survival, as well as exploratory endpoints, including quality of life and the tracking of steroid use. This trial mirrors the design of ongoing, as well as currently on hold trials, including Checkmate 498 and NRG-BN007, specifically for the unmethylated MGMT GBM patients. And those trials, omitting temozolomide was not a barrier for accrual. Also importantly, from our understanding with immune checkpoint inhibitors, that steroids will be only provided if clinically indicated. And this also follows some of the present dual checkpoint inhibitions studies. So again, following precedent of unmethylated MGMT only, no temozolomide, no prior issues with respect to accrual. And then it also avoids T-cell depleting effects from the temozolomide experimental arm. And because it's unmethylated MGMT, this would help shorten follow-up. So thank you. And I specifically want to thank Minesh for his advice, and also my co-investigator Fabio Moto, and also from MEMI for his feedback as well. So thank you.
Thank you so much, Tony. Any questions for Tony?
This is Patrick. Do you think CTEP will allow a single arm study?
Yeah, so I know that we had again, maybe you can comment on this. We had a meeting with you and our stats person as well as other folks in SWOG, and that's a good point. So yes, I think the probability of that would be less. So, but I'd love to hear your thoughts.
I don't remember them ever allowing a single arm study, at least in the last 10 years.
I mean, I think so. Patrick's, I think Bradley's correct. We did run some single arm phase 2 studies out of ABTC. I think the way we hope to proceed with this is, get a call with CTEP, because there's another concept I'll, showcase, which is TRC 102 plus TMZ plus radiation, coming off a study that we did in ABTC, on which, Patrick, you were involved as well.
But that was
trying to
in
see-
recurrence, looking at response rates and things like that.
Yeah, no, you're spot on. So I think if we try to go through it through phase 1/phase 2, we might have a little bit of a option. But the other thing is obviously, doing a CTEP call. You're correct. I think they did tell us that the response rate was the endpoint, and they asked us to hit 30%. But you bring up a very good point. I think Tony, I did speak to Johan, who's our, supports the Hope Foundation. She's very supportive, as well as Chuck Blanky. But I think we should do a CTEP call just with the group there, Bhupinder Man and others, and see if it would even fly. But the other option is that we could launch a randomized phase 2 trial with 3 arms. One is control arm, and then one would be an unmethylated arm with your combo, and then TRC plus temozolomide in the methylated. And Patrick, we could explore that the patients who may have FGFR tag could go all to your concept. But I think, but we'll need much more patients to hit the 100 patients you need for that combo. But no, I think it's an important point. I don't know if we did any ABTC. The V1 studies that you were involved with, Patrick, the AZD,
They were just
AstraZeneca
phase
compound?
1.
Yeah, that was only
Yeah.
phase 1, right?
Yeah, they would never let us do a single arm. Now,
Okay.
there's a lot of interest from FDA using external control arms. So I don't know how open they're going to be, but one possibility is you go in with a single arm study, but with an external control arm as the control.
So
Yeah.
Medidata's synthetic control arms, you mean, Patrick?
Yeah, with patient level data.
We went to them recently, and they really just they said they were kind of sick of us trying not to do control arms. Is basically what they said.
Yeah,
And we're very
CTEP is-
annoyed. I know that Medicina was able to get away with it. I don't know how they were, but maybe I'm getting a different read.
This is from CTEP or from FDA?
FDA.
No, FDA is super interested.
I need to
They
talk to you
they just
because
put in
they-
a guide.
We had a meeting
guidance.
with them 6 weeks ago, and they said they were sick of us trying to get away without doing control arms.
Really?
Is basically what they told us just 2 months ago. So,
Huh.
but maybe they've changed their minds, because I know Medicina was able to get away with it.
I mean, I guess it depends on the context. So, and they're interested enough that they're going to have a meeting with MBTS in July on external control arms for adult trials.
Yeah, I think no, those are really eloquent points. Thanks for bringing it up, Patrick. I think, Tony, what we should do is we should do a follow-up call, and probably at least try to talk to Bhupinder Ban and the guys at CTEP and see, what do they propose, and if they do, we can quickly revert back and try to see how we can do a randomized study. I do know that SWOG itself prefers randomized trials.
Sure.
So on the flip end, And the other thing will be just to, talk to the company and see how much interested they are to, support the trial with the drug to the CREDA mechanism.
Yeah, so
Uh,
I think I forgot just to add that part is that, we've met with Genentech and they've actually have agreed to provide drug funding. So that tells you their interest. But yes, I agree in terms of the arms. That was one of our critiques last time.
Okay. No, thanks. And thanks for input, Patrick and Andrew. With that, we are actually
Yeah,
going
thanks.
to go to the, so thanks for people who are joining online. And like I said, again, I appreciate your staying so late. So feel free to log off if you need to for, getting back to work tomorrow, but we appreciate you being with us. Now we are actually going to go to the speakers in the room. And first of all, I would like to invite Dr. Houghton Schmear, who's joining us from Henry Ford Health System, Department of Neurosurgery. He's done a lot of work in methylation, so he's going to talk to us about serum DNA methylation profiles and diagnosis and follow-up for adult glioma.
I'll just put this in presentation mode. Yeah, let's view. Is that okay? Okay. Hi, everyone. Mami, thank you so much for the invitation, and it's just a pleasure to be here. It's my first time at SWOG, so it's a new environment for me. I'm a PhD scientist. I'm not a clinician, so that's one disclosure I need to disclose. But I'm at the Department of Neurosurgery at Henry Ford, and I'm going to talk to you guys about what we've been doing in terms of looking at serum and DNA methylation, in terms of looking at that at a diagnosis and also follow-up for adult gliomas. Nothing to disclose. So at Henry Ford, we have kind of a unique situation where we're collaborating with both clinicians and research scientists. So every tumor sample that comes into the clinic, part of it goes to the clinic side, and that goes for assessments with pathology, drug assessment, follow-up, and clinical trials and quality of life. And another portion of that actually goes into our tumor bank, where we actually do basic science work, cancer biology, data analysis, and some of the things that I'm more interested in is looking at biomarkers. So for about 15 years or so, I've been really fascinated with epigenetics, and I've worked with epigenetics in a variety of different cancers, but specifically in gliomas. And recently in 2016, we came up with 7 large subtypes of gliomas, where here is indicated here, GSIMP high, GSIMP low, CODELs, which are the IDH mutant subgroups. And those are the classical, like mesenchymal-like, LGM6, GBM, and PA-like, which are mostly the IDH wild-type subgroup. And they all have very distinctive prognostic features. So if we understand the current management of tumors, essentially, if you want to get to that biomarker and to actually define prognosis using DNA methylation, you need to get the tissue out. So this is basically a tissue biopsy, and that's what we've been really working on for the past 15 years or so. If you think about it, it's very invasive, it's painful, and it's potentially dangerous for a lot of the patients. And as we look at this in terms of serial follow-up and surveillance, there are treatments that are done, chemoradiotherapy, and then there's MRIs that are assess progression as well as diagnosis. So if you're looking at the current treatment again, so MRIs are really the hallmark for diagnosis and also for monitoring progression. But however, it's costly, it's cumbersome, it's stressful, significant time away from family and friends, and can actually be challenging to differentiate true from pseudo progression. So although serial imaging is a non-invasive tool to predict progression, what we thought, what could we use to predict tumor progression before disease established that critical mass for visualization? And what could we do to reduce the patient burden and still monitor disease? So if we can find a way to detect the progression early on, then maybe we could potentially do surgery or early intervention. So that brings me to this circulating biomarker theme. There's been a lot of work on circulating biomarkers, looking at ctDNA, cfDNA, extracellular vesicles, you name it, across a variety of different tumor types. And this is not something new. It's obviously been going on for decades. The applications obviously are screening and early detection, diagnosis and prognostication, assessment of treatment response and disease monitoring, and detection of resistance and mutations. So if you essentially look at this from a liquid biopsy point of view, contrast that with the tissue biopsies or even monitoring progression, liquid biopsy is it's simply a doctor takes a sample of blood or other bodily fluid and looks for sign of cancer. as compared to tissue biopsy. It's non-invasive, it's quick, and it's less painful. So as I said, liquid biopsy has been around for many years. And also in gliomas in particular, people have focused on this and trying to see whether they can actually get that cfDNA or ctDNA out. But unfortunately, the accuracy has been very abysmal. It's been almost less than 70% on average with low sensitivity and low specificity. And majority of the reasons why is that people and researchers are looking at targeted sequencing. They're looking at that particular gene of interest that has to be from that tumor into that blood. And so when you look at that from that point of view, it's a bit of a challenge. It's like looking for a needle in a haystack. CSF has also been an alternate source, but if we're looking at this in terms of progression and surveillance, it seems to be more of an invasive approach than simply a blood mark. So we thought, well, why not we use epigenetics? We looked at this in terms of the tissue biopsies. We found different subtypes of gliomas using epigenetics. And when we look at this through the TCGA cohort, when we studied this across 33 different tumor types, you can see that LGGs is really the champion here in terms of the average overall methylation levels across the other tumor types. And that's simply due to the fact because of the association with IDH1 mutation. So we thought, okay, let's use DNA methylation as an approach to detect glioma by non-invasive liquid biopsy to screen and monitor tumor progression and treatment response. So overlaying this with machine learning and then also with MRI images, we can see whether we can actually complement diagnosis or screening using cfDNA methylation. So in this proof of concept study, we have a training set, a test set, and we have our independent validation set, both gliomas and non-gliomas. I'm not going to go into the nuances, but we have a variety of different primary and recurrent gliomas as part of our discovery set. And here's just an ROC curve. It just basically shows you using that independent data set, we're able to get accuracies of over 96%. And what we called a GELP score is a glioma epigenetic liquid biopsy score. Anything above 50% is what we considered glioma. The presence of glioma, anything below that is considered an absence of glioma. So, so here, this is what we looked at in the primary state. That data that I just showed you was all at primary state. So anything above 50%, as I said, is the presence of gliomas. We also had matching recurrence for 33 patients across 71 samples for both first, second, third, and then also off treatment or follow-up. And what you see here is that there's actually a downward trend of the GELP score from a little bit higher above 50%, and then there are some patients that actually drop below 50%, indicative of a non-glioma. So we had some patients where the score stayed the same, some where it increased from low to high, some that decreases, and then some that went increase and decrease, and then back up and down. So what we did is when we actually looked at the clinical data associated with that to see why we're observing these differences in longitudinal aspects and basically looking at surveillance, we saw groups of patients where they actually resisted therapy. So these are two examples of patients where they started off as a GBM. The GELP score was a 51, indicative of a glioma. Recurrence occurred about 6 months later, and the GELP score increased from a 51 to an 82. Here's another patient where it started at 51, and then it increased to a 78, and it subsequently passed away after a year. We also found groups of patients where they responded to the therapy. These are long-term survivors, and you can see here the GELP score started at a 93, and this patient here for 6 years with no sign of progression at all came back into the clinic as a routine checkup, and we got their blood, and their GELP score is way below 50%, indicative of non-glioma. So this is really clearly showing that our score can correlate well with different types of gliomas in terms of the response to therapy. This one's an interesting case where the patient actually started off with a 98, very indicative of a glioma. About 2 years later, the patient didn't have any sign of progression. It just had an infection at the site of a surgery. They went in for cleaning. They drew their blood, and you can see the score drop actually to 78. Still indicative of a glioma, but it was much less than its baseline score of a 98. About 5 years later, or 4 years later, the patient came back with the sign of progression by MRI, and our GELP score correlated with that, and it actually increased from a 78 to an 87, and the patient is now undergoing therapy. So I thought I had more time, but I wanted to keep my talk short, so I didn't have time to go over some of the other nuances that we had in our paper, in our study. But just to show you that we've actually applied the same approach to 2 different tumor types, pituitary, which we just published in 2022. And then we have another paper in meningioma. We call it the MELB. So we have the PEL for pituitary, MELB for meningioma, and the GEL for the gliomas. And the meningioma shows a very high reproducibility as well. And one interesting thing about the meningioma is that we can actually predict recurrence. So those that are high risk for recurrence versus those that are low risk for recurrence, we can actually predict that using blood and serum. And hopefully that'll be out soon, hopefully earlier this year. So with that, I just want to acknowledge our department and generous donors and public funds for their support for this project, and obviously our patient population. We have just a wealth of patients at Michigan, where patients do not migrate out; they stay and they get retreated constantly, generations and generations. So we get very nice longitudinal clinical history. So there's a group of people that are involved in this, my lab, as well as other lab members in the Department of Neurosurgery, as well as the funding support from NIH and Department of Defense. Thank you very much.
Thank you for your great presentation, Houghton. Any questions for Houghton? If not, I have one. So what would you think is the applicability of the work that you've done? How would you like it to be integrated either with clinical trials as we envisioning, or collaborations that we may do via SWOG or outside SWOG?
Yeah, that's something I've been thinking about as well. Like, if we're thinking about this as so we've got some additional data that I didn't share with you. It's still very new, where we've actually collected patients off treatment. So we're actually following them at time of MRIs. We've got the liquid biopsy scores, and we can actually show differences between pseudoprogression and progression with MRIs. And our scores actually does a lot better than its conventional MRIs images, where it shows contrasting of a tumor, and then our score actually shows that it's a non-tumor. So in terms of clinical trials, yeah, I can kind of see this as an opportunity to improve on the quality of life of the patients. If we can actually detect these particular cases in like pseudoprogressions and true progression, if we can differentiate that, I think that will improve the quality of life. That might even actually improve therapy. I'm not a clinician, so I can't really tell you exactly where we could lead with this, but I just envisioning improvement in quality of life. And I would love to see an opportunity where we can apply this as a clinical trial. We also have data where we can actually differentiate high grades and low grades, IDH mutants and IDH wild types, all at diagnosis prior to, so this is at time of surgery, all using epigenetics and liquid biopsies. So if we were to know a patient is an IDH mutant or an IDH wild type before even surgery is done, I mean, I can imagine that would be paramount. I mean, that would be revolutionary in terms of treatment. Yeah. Maybe you want to go up to the microphone. Yeah.
I want to speak in the mic. Yeah. We still have 10 people.
Very exciting. Hello. Okay.
Yeah.
Very exciting topic. Thank you so much for your talk. Do you have a correlation between the GELB levels, and is it correlated with the enhancing portion of disease, or with just T2 flare non-enhancing?
I wish I kept my slides. I was concerned about the time. I had all these slides with the imaging and everything else. So we didn't actually look at the correlation with the different flares, T2, T1, and all those kind of stuff. We did, pathology, the radiologist said that there was an enhancement there, and it was clearly showing an enhancement. Our GELB score showed, for that particular patient, when the pathology came back, it showed necrosis or radiation necrosis or gliosis. Our score was way below 50%. So that shows us that our score, and so we had 3 patients that were this classical pseudoprogressed cases and they're still doing really fine. I mean, there was surgery done on them, but they're still alive, 5 years out. But they had this image of enhancement, and then the score, and then the pathology shows radiation necrosis, and our score was way below that. So there is good correlations with our GELB score and pseudoprogression and enhancements. Yeah. Yeah. Well, I guess it would be anti-correlated, but yeah. Okay.
All right, wonderful.
Okay.
Definitely, Houghton will be available after the meeting. So if anyone wants to talk to him about collaborations, please do that. Next, moving on, it's my distinct pleasure to invite Dr. Alireza Manzouri, who's really a neurosurgeon who's making his name both in the translational space as well as radiosurgery world. And he's been working a lot on phase 0 trials, CSF related work, some which I've had the pleasure of working with him. And today is a concept of a phase 0 trial of repurposed azoles for glioblastoma. And he's going to tell us about what he's working on. If only I can figure this out.
All right, good evening. Thank you very much, Dr. Aluwalia and the SWOG group for and giving me the opportunity to talk about our phase 0 concept revolving around repurposed azoles in glioblastoma. This is work that's currently underway at Penn State. The foundation for this concept is rooted in years of work in Dr. Zade's lab. As most people in this room know, glioblastoma tumor cells, like most malignant tumors, are dependent on the Warburg effect to switch their metabolism in low oxygen situations to generate energy. And Dr. Zade's group was able to show that HK2 is a very central player for the Warburg effect in GBM. So later, Dr. Agnihotri, the first author on this paper, conducted a really neat study where he wanted to look at currently FDA-approved drugs that can be repurposed to modulate or inhibit HK2 regulated pathways, not just HK2 enzyme itself, but the pathways without harming normal human astrocytes and neurostem cells. And through this work, he was able to identify ketoconazole and posaconazole as potential candidates. And in vitro, they were able to show efficacy in tumor cell kill, and in vivo, they were able to show increased mouse survival. And furthermore, analysis of the tumor cells demonstrated greater apoptosis, decreased angiogenesis, and decreased production of lactate and pyruvate. So in addition to just the effect of metabolism, which would be HK2, there are other effects clearly going on as well. So this is an attractive concept. As we know, drug repurposing is attractive because it's potentially can save us years of drug development costs and time and patient resources. So the impetus is high to move on to humans. But as we've known for many years, we've cured a lot of drugs in mice and tissue culture, but the question is, does it work in humans? And as Dr. Sanai highlighted way more intricately than I can right now, there's a value for phase 0 trials, which give you a very quick go, no-go signal. So very limited number of patients, and is there any hope for this drug? And so through this phase 0 design, we would be able to hopefully assess whether or not these drugs can penetrate the brain, accumulate in sufficient concentrations in the tumor, demonstrate the biology that we saw in mice, and hopefully we can determine the neuro PK, which can potentially be different from a systemic PK. And that has ramifications for drug dosing if we're ever to move on in a future phase 1 or 2 study. So the overall design of this is a single center, open label, non-randomized trials, and microdialysis catheters form the central tenet of this study. The way we've designed it, we're going to enroll 5 patients in the PCZ arm, 5 in the KCZ arm, and 5 in control. And as Dr. Sanai mentioned, we are also trying to do steady state dosing. So that's about 5 half-lives for the drug. And so depending on the drug half-life, that affects whether or not the patient can be eligible for that. So if the patient needs surgery, but on an urgent basis, they may not be a candidate for a drug that needs to be given for 7 days, for example. So our goal is to try to enroll in the PCZ arm first because it's a cleaner drug in terms of drug-drug interactions, has a little bit of a better brain penetration. If that arm is completed or there's contraindications, including urgency of surgery, we move on to KCZ assessment. If there's contraindications to that, or if it's completed or the patient does not want to get any drug but is interested in participating in the study, they go into control arm where they only get the microdialysis catheter. For brevity, eligibility involves any adult patient who on imaging and clinical history looks to have a high-grade glioma. We check liver and renal labs and ECG at baseline, depending on the drug, and we look at the timing of surgery. So for ketoconazole, both of these drugs have a kind of a messy half-life, but for KCZ, you achieve 5 half-lives steady state within 48 hours, and posaconazole within 7 days. But to increase flexibility and give ourselves a little bit of more of a window, we made it 2 to 5 days for ketoconazole, 7 to 10 days for posaconazole. And so here's the schematic diagram. I'm sorry it doesn't project too well, but the idea again being someone has an adult has what on imaging appears to be high-grade glioma. They need surgery, but not urgently. They can wait about 4 or 5, 10 days. And so they get the drug, they take it daily. And when they come for the day of surgery, they take another dose of drug in the morning as scheduled. And then the tumor is resected. It goes to the lab for analysis of drug concentration, metabolite concentration, and various PD parameters. Once we're done with the tumor resection, we insert microdialysis catheters. The evening after surgery, we get a CAT scan to make sure there's no complications. And then the next day, they get the final dose of drug, and then we start 24 hours of dialysate and blood sample collection. And this works out from a logistics perspective. So at the IV center, then they have all of this worked out. But for us, you would wonder, like, can they stay in the ICU for 24, 48, step down 24, 48 hours? We give 5 ALA, they need to be in the dark for 36 hours anyways. They have an art line, so this all works out quite well. And this is just a schematic of how these things are put in. They're very flimsy. So we try to put one catheter in enhancing tumor, if any left, and another one in the non-enhancing tumor resection cavity, with the idea being to assess drug penetration based on regional variability of BBB breakdown. These catheters, they look like this. The one we're using is about 10 centimeters long with a 1 centimeter gold tip that is visible on CAT scan as shown here. These are this end gets connected to the pump. This is a microvalve that collects the sample. And the idea is that we pump artificial CSF through, and it circulates in the brain interstitium, and based on a concentration gradient, you exchange the metabolites or drug. There is a pore size limit, and the ones we're using are 20 kilodaltons, so you won't get antibodies, you won't get protein-bound drugs. So these are nuances of that. When we're ready to collect dialysate fluid, we start to pump 1 to 2 hours before time zero for a number of reasons. One is to make sure it's working, to get the air flushed out of the system, but also to have some fluid for time zero. And for reasons I'll show later, we set the pump at 1 microliter a minute. And these are the time points that we synchronously try to collect dialysate fluid and blood. The main outcomes we're looking at primarily is drug concentration in the tumor. If the drug does not get into the tumor, then there's no point in going any further for the most part. Secondarily, we're looking at neuro-PK, which is basically dialysate-based free drug concentration in the brain over time, metabolite concentrations in the resected tumor, specifically lactate and pyruvate, and we're also going to look for those in the dialysate and other PD parameters. This study is very mass spec heavy, so we're lucky to have Dr. Neighbors' collaboration at Penn State. We've already calibrated for the spike pattern of control tumor and KCZ and PCZ. And we're going to use this for drug concentration in tumor and in the dialysate fluid, and looking at lactate and pyruvate in the dialysate fluid. The pharmacodynamics we're going to look at, we will look at baseline differences in HK2 mRNA expression, just to make sure there's no major variations in tumors. So I actually discussed this a few years ago with Dr. Sanaya when I was trying to design this, and ideally you would get archival tissue, but just by virtue of this being a single center study, it's hard to get enough number of recurrent tumors that we have bank tissue, and there may be differences between the primary and recurrent tumor HK2 mRNA expression. So the trade-off did not appear to be too worth it. And then we look at HK2 enzyme activity to see if the drug directly inhibits HK2 activity. And then in addition, we're looking for apoptosis angiogenesis, which is what we saw in vivo being affected, and lactate and pyruvate levels. Metrics for success. Some of this are based on clinical practicality, relevance, and the other is based on our in vivo data. So in the mice, we saw that we were able to detect 500 nanogram of drug per milligram of tumor tissue. And so if we can detect that in 2 or more of the 5 patients in either arm, that's great. That's potential grounds for success. So if we don't see any other PD effects, does this make the case of a dose escalation study, for example? Because the doses that we have picked are the lowest doses that we're currently using for CNS infection that are deemed to be safe. If we also end up seeing reduction in average lactate and pyruvate concentration in the resected tumor from treated patients versus control patients, that's exciting because that's an indicator that it's having some of the metabolic effects. And in addition to that, and obviously we're looking at other PD parameters, as I mentioned. And in addition, the cherry on the top would be if we see stability of dialysate concentration of lactate and pyruvate in control patients, but steadily increasing lactate and pyruvate concentration in drug-treated patients, because the last dose of drug was time zero. So theoretically, as that is coming out of the system, if the lactate and pyruvate concentrations go up, it shows a direct relation between them. It's going to be harder to see that in theory at steady state dose of drug, but we'll see. Progress to date, it's been about 1 year. We're projecting 2 years needed for accrual. This is our progress so far. So PCZ is a cleaner drug in terms of less drug-drug interactions, but the 7 to 10 days has made it challenging to enroll. KCZ on the flip side has many other interactions. So that is why for the most part, we've had more luck with control patients, but we're almost halfway there and we have 1 more year to accrue. So hopefully by next year, this time I can show you data. And so finishing off with some notes and lessons learned. So these microdialysis-based studies end up being more complicated than they seem. So first of all, at the end of the day, there's a plastic tubing involved in these catheters. So if your drug is hydrophobic, it can get stuck to the tubing. So it's essential to establish the in vitro fractional recovery. So if you have 10 micromolar of drug in a beaker, but you only recover 1 micromolar, then you know it's 10%. So you got to account for that when making your final calculations. And then the flow rate of the pump is important and the storage conditions. So we set up all these matrix of experiments. The pump can go from 0.1 to 5 microliter per minute. No one in the literature is really using 5, and 0.1 is impractical. We tested it nonetheless. So we found 1 microliter to be optimal, and minus 80 degrees Celsius was best for our drug. These pumps are very fragile, so even if you see these flashing green lights, if there's any back pressure on them, the pumping mechanism can fail. So I decided to have multiple backup pumps and always testing the pump function for each patient on expired catheters to make sure you're getting the expected recovery. So if you're set at 1 microliter a minute, after 60 minutes, you should have 60 microliters. If not, something's not working. And the microvials, they should in theory hold 200 microliters, but if you push it past 120 microliters, there's again back pressure on the pump, potential for leakage. So we don't collect any more than 120. And even though they look like they're sealed from top and bottom, we wrap them with parafilm because the sample can evaporate or leak, as we found in our preclinical studies. So huge thanks to my mentors, Dr. Zade and Dr. Connor at Penn State. Dr. Zakir is my neurosurgical colleague, people in the lab, my fellow, and our research coordinators, and NIH R03 and American Cancer Society funding. Thank you.
Questions for Dr. Manzoori? Okay, no one online has a question. That's probably late in the night. I can feel it myself. But Ali, is a great talk and great work. And again, following up on work with Nader's doing extremely important work. So what do you see
I
as
had
next
one
steps?
question,
As
too.
Nader said, right? This is really Nader, do you have a comment?
Yeah, but go ahead. I can ask afterwards.
So as Nader alluded to, right? So these studies are extremely complex, right? And they need a whole milieu of multiple steps. And even Nader showed the people in the OR who need to be trained, right? So how do you see scaling this up? Or do you just see, as Nader sees it, doing it his own institution where he's able to control things? Obviously, volume becomes an issue, but at Barrows, probably they don't need many other sites. So what are your thoughts for the next steps?
Yeah, so just going back to the culture thing, I couldn't agree more with Dr. Sinai. We thought, everyone would be on board, no problem. But turns out if a patient shows up on the ward with a microdialysis catheter, everyone freaks out. So we ended up making laminated cards about the processes and what these catheters are, et cetera. So everyone was happy about that, some presentations. And the more we do these kinds of studies at the institution, I think everyone gets a little bit more comfortable. But yeah, I got to admit, it's been very challenging. I'll have to put my own time. In terms of next steps for this, as I mentioned, if there's any penetration of the drug into the tumor, but no PD effects, then that could make the case for dose escalation studies. If all those metrics are successfully met, then I think we have a case for phase 2. I think for an institution like ours, a phase 0-2 or an expansion arm will be very challenging because we simply don't have the ability to run the mass spec and look at the PK and all those parameters. So I think those kinds of studies would be best run at Barrow. We simply cannot do it at our kind of center. But I think we should try to, I like the idea of assessing the brain tumor microenvironment, whether it's through the Omaya catheters in the cavity or these microdialysis catheters. They're all very finicky, especially these microdialysis catheters. But I think we should, as a group, consider more of these studies. What can we gain by studying the extracellular fluid in the brain interstitium that we're not otherwise doing? So for example, Endoam at Emory, he's looking at cytokines and immunotherapy, and the cytokines are great for microdialysis catheters. And there's others at Mayo Clinic in Minnesota and at Rochester. They're looking at high rate perfusion of drug into the tumor cavity in low-grade gliomas using a pump, and then measuring other PD effects. So I think we can get quite creative if we are open to these kinds of studies. You know, traditionally, oh, it's an implant, risk of infection, risk of brain injury, etc. We're doing them. We need to do more of them, and I'm glad we're getting the platform to talk about these things.
Nader, you had a question or a comment?
Yeah, just a quick question. What do you think is the most significant barrier for you for accrual?
That's a great question. So everyone asks, you know, and people have been quite generous, but what is in it for me? Like, is there any therapeutic benefit? And obviously we have to be upfront. We have zero promise that there's going to be any therapeutic benefit. You're not going to get this after the surgery is done, after the catheter is removed. So that's been the greatest barrier. And a majority of these are primary GBM patients that have just been hit with a diagnosis, and we're telling them, okay, here, take this drug, you're going to have a catheter in your head. So that's been a major barrier for us.
Yeah, it's certainly an ambitious protocol. So congratulations on all the work you've done. It will take time, but I think it will be worthwhile.
Thank you.
All right, and if no other questions, thank you, Dr. Manzoori, for joining us. And basically that means I'm the person between you and the prey. And you know, just being from East Coast, I can feel the jet lag by self setting in. So I'll try to keep awake and try to make it succinct. Okay, perfect. So this is a concept of TRC102 and temozolomide in newly diagnosed MGMT methylated glioblastoma. So obviously, Dr. Tony Wang had presented his concept in unmethylated, and this is building off some work that we've done for the last several years, and I'll talk you through this journey. You all know what GBM is, so I'm going to skip through this. We also know that, you know, newly diagnosed glioblastoma is treated with radiation and temozolomide, followed by 6 months of 6 cycles rather of temozolomide with or without Optune now. And we also do know that the bulk of the benefit lies in the methylated group, as Dr. Wang had alluded to. And MGMT methylation, promoter methylation, you know, the mechanism is it prevents production of the repair enzyme. And as a result, these patients get benefit from temozolomide. So we actually ran a study with TRC102, which is a base excision repair inhibitor, was a drug developed by Dr. Stan Gerson, who was the cancer center director of Case Western Reserve University, the comprehensive cancer program where I was for over a decade. And essentially, as you know, when we give patients with glioblastoma, temozolomide forms 06-methyl guanine, 7-methyl guanine, and 3-methyl adenine adducts. And essentially, we do know that the 6-methyl guanine DNA adduct is repaired by MGMT, but the 7-methyl guanine and the 3-methyl adenine is actually removed by the base excision repair pathway. Essentially building on this, Andy Sloan, who was at Case Western at that time point, had done some xenograft experiments, and he showcased that if you used the combination of TRC102 along with temozolomide in CD133 positive glioblastoma orthotypic xenograft models, you actually saw success. And TRC102 is a base excision repair inhibitor that binds to the apurinic site created through the action of methyl purine. So essentially, we built this phase 2 trial that was done through the Adult Brain Tumor Consortium, the consortium that was run by Skip Grossman through Hopkins and was supported through CTIP and NCI mechanism, and unfortunately has now, you know, it's no longer in force. But essentially, this was a phase 2 trial of bevacizumab naive patients. And here we were able to really run a single arm phase 2 trial. And as Patrick and I were talking about them not allowing phase 2 single arm studies, at least in upfront setting, we got a pass in the recurrent setting, but our target was to achieve a combination therapy of response rate of 30%, which is all of us who do or treat glioblastoma patients think that's almost unheard of, or rather unachievable. So we treated 19 patients, and the median age, median KPS were all comparable to all the number of trials we've all seen, which have unfortunately been negative. So overall survival was 11 months, progression-free survival, basically 2 months. That's the time to your next MRI, which is the story of our lives, unfortunately. PFS6 was 10.5%. But 2 patients that I treated, actually, we ended up calling them exceptional responders. They actually had a progression-free survival of 18 months, and the other one was over 30 months. So which got us thinking. Lisa Rogers, who was at Case Western, did a bunch of correlative studies looking at methyl MPG staining and found some correlation with MPG expression with both these patients who did well. Combination was safe. There was hardly any toxicities. But what was exciting to us was when we looked at the historical controls, we do know that those patients who are recurrent glioblastoma, the survival is around 9 to 12 months. Unmethylated patients around 8 to 9 months, and those who are methylated MGMT, they are 12 months or so. So in our cohort, 5 patients, there were only 5 patients which were methylated. We at least had a overall survival of 30 months, which was interesting. Now, obviously, very wide confidence intervals because there was only 5 patients. So the lower end is 9.5, but the couple of patients did really well, especially the exceptional responders. Both of them were methylated. The unmethylated median overall survival was 10 months, very comparable. But there was obviously a difference between p-value, which is again is not a surprise. You've seen that quite a few times. But what was very interesting was that in MGMT methylated patients, this appears promising, although with small numbers, I'll admit. But meanwhile, we were doing collaboration with Mike Behrens, and we ran, whole genome and transcriptome. And what he showcased was that there was an overactivation of the DNA damage response pathway on transcriptome. And 2 patients actually, who you can see here on far right, actually had a gene signature which can be used as a biomarker. And this person who's highlighted here in the middle, it's not projecting very well on the screen, but essentially this patient, again, I treated, progressed right after 6 cycles. So we know that it's 28-day cycle, so they did not hit the 180-day mark, but they were just right, like 174. So it's interesting that someone who had a borderline signature had a borderline benefit, and 2 patients who actually had the signature hypothesis generator were both the patients which did well. So biologically, it makes sense. You're doing a double hit, approach in MGMT methylated, hitting it with temozolomide, which we know is repaired by the MGMT pathway or the PACE excision repair pathway. So, so there's some excitement about it. We actually have submitted the publication. Ahmed, who's in here in audience, helped us put the paper through. It's under review right now. But essentially what we are doing is we are, proposing this phase 1 study, open for it to be phase 2, especially given Tony Wang's concept, whether we go in together, to having a trial for both methylated and unmethylated patients. And essentially now we want to do this in prospective setting with TRC102 given along with temozolomide. And when we use the combo, it was extremely well tolerated. There's some anemia, but not significant. There was not extensive myelosuppression. And essentially, the intent here is that this will only be in the methylated patient population, and we will validate the DNA damage response pathway actually in a prospective manner. So that's my concept. And with that, I'll open it up for any questions that people have. So we can, frankly, I mean, again, I wouldn't be opposed to it, especially with, the data for Optune. Again, you cannot take Optune. We've all struggled with this in various cooperative groups, through NRG. More recent trials are now including, use of Optune because, it's on the NCCN guidelines. There is a survival benefit there. And I don't feel that you can, preclude people from using access to Optune. We don't foresee that as a challenge, but when we build trials like we did with, I see Paul Brown's on call as well, but with John Sarkaria's study with the PARP inhibitor, they did allow it, and so some of the newer studies are allowing use of Optune, and that does make our life a little bit more complex. Takes around 25% on most studies in large scale community trials, but we certainly would be open to. I don't have it on the schema, so great point. I would be very open to including that. Hearing no questions, I would like to thank everyone. So as next steps, we'll do a call with the CTEP again to get an idea of this one. We can obviously do it through phase 1 and it could go through, but it's a fair amount of work. We also know through a cooperative group, and I do know SWOG strategies for larger trials because it's a bigger bang for the buck, frankly. So what I do know is that CTEP's interested in supporting this trial because they've had a drug. They've been part of our previous study through ABTC, and I spoke to the company CEO. They've actually, all their trials are being run through CTEP. They just supported a new trial in lung cancer, and they're very interested in supporting a GBM study. So we'll probably what we'll do is Maggie's here in the audience. So if you want to share your emails with her, if she doesn't have it, and we'll do a follow-up call of the working group to follow up on the core concepts that we had today, and also, other investigators who presented their stuff to talk about correlatives and if we can build some of these correlatives going forward. If no comments, I really thank all of you, and also thank Maggie for getting us together, and to the SWOG team, but also most importantly to Johan and the Hope Foundation, which actually gave us a nice grant, which aided in supporting the travel of numerous speakers that we had today. Thank you so much, and have a nice night. Hope everyone gets some rest.
Thanks, Mamie. Have a good night.
Yeah, that's